Hi, I'm Dr. Sarah Hurvitz. I'm at UCLA. I'm a medical oncologist specializing in the treatment of breast cancer.
Hi, my name is Tony Rivas. I'm a professor of medicine at UCLA. I'm a medical oncologist and I treat melanoma.
Yeah, so the actual abstract won't be released until June 3rd, but there was a press release describing the data that I can share with you. So trastuzumab emtansine, E-M-T-A-N-S-I-N-E is the new name for it, is a really kind of novel molecule. It's trastuzumab, which is a monoclonal antibody targeted against HER2, which is linked kind of in a beautiful way. A very stable linker links it to a derivative of maytansine. Maytansine was an incredibly toxic chemotherapy agent developed in the 80s but shelved because it was so toxic to humans. So Genentech has figured out how to link it stably to trastuzumab so that the maytansine is not released until the trastuzumab has bound to the HER2 and been internalized inside the tumor cell. It's taken up into a lysosome and then released. So it's truly targeted delivery of chemotherapy, and it is a very novel approach. So we first presented phase 2 data comparing TDM1 to docetaxel trastuzumab at the European Society of Medical Oncology last September in Stockholm, and showed that in a head-to-head comparison in first-line HER2-positive metastatic breast cancer, the TDM1 had a significantly longer progression-free survival associated with it, 11 versus 6 months compared to standard chemotherapy plus trastuzumab. And the safety profile was profoundly better. So this study that's being presented at ASCO is Emilia, and it's the phase 3 study comparing TDM1 to lapatinib capecitabine in trastuzumab pretreated disease. And what they will be presenting is the progression-free survival data from this study, which we know is positive. They have met their primary endpoint. I'm sure safety data will also be presented, but survival data will not.
And you think that being positive is because on one arm they're targeting the signaling from HER2, on the other one you're delivering a toxin, right?
Yes, exactly. And so the targeted delivery of the toxin may be making it more effective. There's some theories that maybe there's increased ADCC. That's preclinically supported by some studies, but it's somewhat interesting to think about the differences in the way that these molecules work. Well, that is probably the biggest one that's going to be presented. There's a number of smaller studies looking at TDM1 in combination with pertuzumab. Pertuzumab is like trastuzumab. It binds to the extracellular domain of HER2 at an epitope that's different than that's bound by trastuzumab, and it prevents the heterodimerization with HER3, which is the preferred partner with HER2. So combining that with TDM1 may be particularly effective, and there's going to be some phase 1 and I believe phase 2 data looking at the safety of those approaches. And I think Genentech has a study, phase 3 study called Marianne, looking at the combined approach of these two drugs. So that data would be expected in the next year or so, I would think, because that study's recently closed. So in my own practice, I've not changed my own practice in the use of GCSF. I basically follow the American Society of Clinical Oncology guidelines and use these agents when the risk of neutropenia with a fever is high enough to warrant it. The types of regimens that we use specifically in breast cancer are often, when they're taxane-related regimens, they often do warrant the use of prophylactic agents. I haven't noticed any changes in the practices of my colleagues, although I'm not working closely with people who are outside of the breast cancer specialty. So perhaps Dr. Rivas could comment on this a little further.
No, not really, because in melanoma we haven't used much chemotherapy. It's a disease where chemotherapy doesn't work well, so supportive agents for that are not that pertinent, and we focus on targeted therapies and immunotherapies.
Yeah.